Well, as I mentioned, the Toronto Sun reporting that 416 pink slips going out to employees in the local health integration networks and other provincial health agencies. And that report suggesting more layoffs for public sector health workers in this province. We just told you about the rally that was held last night, just prior and during the board meeting, the public school board meeting yesterday. We found out, we received an email from Windsor Regional Hospital about at least closing partially or altering partially their high-risk pregnancy clinic, which is their maternal fetal medicine clinic. Joining us right now to talk a little bit more about this, the chief of OB-GYN for Windsor Regional Hospital, Dr. Greg Hasen. Good morning, Dr. Hasen. Thank you very much for joining us today.
Yeah, thank you very much, Lynn. Good morning.
Can you first of all explain what the clinic has been and who it served?
Well, the origins of the clinic started about 18 years ago, where we've been attempting to upgrade the funding for our hospital to a level 3 high-risk hospital. And it sounds a bit confusing, but the level 3 hospitals would be with the NICU, neonatal intensive care units, to care for babies that are preterm. Level 2C, which is what we've been funded as for years and years, would look after patients that are 30 weeks and over, and anyone less than 30 weeks would have to be transferred out to a level 3 center, the closest being London. However, for the last 32 years, we've actually acted as a partial level 3. We've been working, looking after patients usually 28 weeks and above, and for the last number of years from 26 weeks and above. So the maternal fetal medicine program was sort of part of that, and ideally we need 2 MFMs, specialists, to help look after those high-risk patients, as well as the critical part is more having a team of neonatologists that are available 24 hours in hospital. We have 4 excellent neonatologists, but we don't really have the manpower to have them, in hospital all the time. So the hope was that to build up that unit in order to acquire funding, and that's really it's not come down the pipeline, and it doesn't look like, with fiscal restraint by the government and limited coffers and expenses of healthcare continuing to increase, it doesn't look like we're on the horizon for becoming a level 3, and the hope is we're striving still for that, but it's probably likely going to come more when we acquire a mega hospital.
So this is a result, you feel, Dr. Hasen, or not, of funding changes by the province at this point?
Well, it's not so much funding changes. It's been the funding that has been existing. So we've been always underfunded for our hospitals. So we've always been cutting back the fat, so to speak, and trying to make fiscal decisions that wouldn't affect patient health or patient care. And we are we've cut so much fat that really we can't cut anything else, and yet there still isn't enough money coming in to account for the cost of running care.
At the level that you wanted to do it.
At the level that we would like to. Okay. Exactly. So we've had an independent utilization review by an independent company set up by the government, and their main recommendation was that for our department, so each department this is women's and children's, we have to come up with $630,000 in savings, and a significant portion of that is the MFM clinic. And we carefully looked at that. It was nice to have. Dr. Mundell has been sort of an asset to the community and sort of upgrading our ability to look after higher risk patients. So I think he's helped us set up protocols for HIV patients, for methadone patients. And we've been doing that in his absence, when he's away, when he's not on call, on weekends. The 12 other obstetricians that are here are really looking after his high-risk patients. So I think it's upgraded our ability to look after those patients as well. There are certain high-risk patients that would be seen here that really we can care for, but the babies would not be served best here. And for example, those with cardiac anomalies that are diagnosed in utero, pretty much all in Ontario, they would go to Mount Sinai in Toronto. So we will make those referrals directly, simply because Dr. Mundell can look after them as well here too, but the babies can't be cared for here. So they're better to be born in the center where they will require the care. So it's usually not deliver here and then transfer. It's transfer the mother to that location. Some of the GI abnormalities, fetal anomalies, or complicated cases we think would best be delivered, say, maybe in London. And we've been doing that all along. So there's not a lot of patients, but there would be a number of patients that might still affect.
So who are the patients and babies, I guess, both moms and babies, that will still be treated here at Windsor Regional Hospital when we talk in terms of high risk?
I would say the majority of those patients. So 26 weeks and over, we would deliver here. If they're less than that, our NICU is not capable of sustaining care of those babies. They can stabilize them, but if we can, we try and transfer those babies or those mothers to the nearest center, and that's where we use Critical. So if London is full, they may go, as far as Ottawa, to wherever there is an NICU that's capable of looking after anything less than 26 weeks.
Wow.
We're still funded as a 2C, but we are acting as we say, as a sub-level 3 center. Critical Care Ontario has taken overseeing the management of all the NICUs for Ontario. Two of our hospital managers sit on that committee, or there's 2 working committees, and as of Tuesday night, there's no change planned in our level of care by Critical Care Ontario.
Will they ever be transferred to Detroit? I mean, when you talk in terms of going as far as London, or as far as Ottawa, excuse me, would they be able to go to hospitals in Detroit? Yes,
we make that on a case-by-case basis. Our protocol is we call Critical Care Ontario. They would put us in touch with, they contact all the NICUs that are available with openings, and then we discuss with them whether it's prudent to, from a time basis, if we feel that there's an emergency, this patient needs critical care, and we can't wait for, say, Orange to come down and pick up the patient, then we make that decision with Critical Care. We need their approval, but then we would transfer them to Detroit, and we have done that not infrequently.
Okay. So we are not talking about a great number of women and babies that will be affected by this change. Do you have any hard numbers on that, or?
We don't have hard numbers. We're estimating it might be 1 or 2 patients a month that might need to be transferred out, or mothers. Now, mothers may need to go to London for a consultation to see one of the MFMs there to determine, is this something that we would manage here or best be managed in London? And that certainly is happening currently as well. So I don't think that there would be a significant increase in the numbers of those patients that would have to go. So we don't think it's going to have a significant impact. As I said, it's been beneficial having Dr. Mundell as an MFM here, but I think we are doing more and more of those kind of moderately high-risk patients anyways through our sort of improvement in our expertise looking after them.
Okay. And you see possibly this coming back when we receive our acute care hospital?
I think as we get closer to the mega hospital, then this is the program that we are hoping to develop, looking forward to the future. And I think as the population increases here, we'll have more numbers to make that more fiscally, reasonable.
Okay.
From a government funding point of view as well.
Yeah. I mean, and when you hear reports out today, and the report is not confirmed as of yet, but we are looking at perhaps more funding cuts when it comes to health services in our province. It's not very good news, I don't think, for any hospital or any program, any Lynn, within our province.
No, my understanding from our meeting the other night is there's at least 50 hospitals in Ontario that all feel that they're underfunded. We were one of the first to do the win-win by amalgamating hospitals, but because our funding formula is based on your data from 2 years ago, we're always been behind the 8 ball, and we've never been able to catch up. So we've been trying to trim fat and to run things as lean as possible, and we just, to the point now where we can't get any leaner. So we either get more funding or we're going to have to start dropping programs. And this is one program that was recommended that, you're not funded for this. It's nice to have, but you really can't afford it.
Right. Dr. Hasen, thank you so much for joining us today and laying it out and explaining it to us. Dr. Greg Hasen, Chief of OBGYN at Windsor Regional Hospital, talking about some of the changes for high-risk pregnancy patients and their babies. The maternal fetal medicine clinic will continue to operate, however, somewhat limited, as you just heard. Okay, so I know it got kind of complicated when he was explaining, 3C, 2C funding options, but basically they will be able to help many of the women and children still, but there simply is not funding available any longer because of cuts that needed to be made to help everyone under this program.